Hello, I am Toska, and I will represent a case report for a woman with antiphospholipid syndrome, a case report. Antiphospholipid syndrome is a systemic autoimmune disorder characterized by thrombotic or obstetrical events and the persistent presence of antiphospholipid antibodies known as lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein in the patient's plasma. The Sapporo criteria for antiphospholipid syndrome classification, first published in 1998, then revised in 2006 as Sydney criteria, required at least the presence of one clinical and one laboratory criterion to classify as antiphospholipid syndrome. Clinical criteria include vascular thrombosis or pregnancy morbidity, and the laboratory ones include the presence of medium or high titers of IgG and or IgM of anticardiolipin, IgG, IgM, anti-beta-2 glycoprotein, and or lupus anticoagulant positive on 2 or more occasions at least 12 weeks apart. Antiphospholipid syndrome may occur as a primary disorder or in association with autoimmune diseases, especially with lupus erythematosus. Antiphospholipid syndrome is an autoimmune condition which may potentially cause adverse pregnancy outcomes such as recurrent miscarriage, stillbirths, severe preeclampsia, and severe placental insufficiency. One of the features of placental insufficiency is intrauterine growth restriction, defined as a fetus that has not achieved his or her growth potential. A 36-year-old woman who experienced 2 unexplained intrauterine growth restriction in both pregnancies suffered a stroke after giving birth to the second child on the first day of the 36th week of pregnancy. A series of examinations were started to discover the cause of this situation. Initially, was noticed that transaminases were elevated in this woman's serum, respectively AST 125 units per liter and ALT 172.8 units per liter. An abdominal computed tomography is immediately realized, which resulted normal, suggesting for an autoimmune condition. Antiphospholipid syndrome was suspected as a potential cause, and this patient underwent several examinations. She was tested for antiphospholipid antibodies like lupus anticoagulant, 3 isotypes IgM, IgA, IgG of anticardiolipin, anti-beta-2 glycoprotein, phosphatidylserine, phosphatidylcholine, homocysteine, antinuclear antibodies, and ENA profiles were also part of the laboratory control. The result of this examination showed positivity for beta-2 glycoprotein, anticardiolipin, phosphatidylserine, phosphatidylcholine IgM. ENA profiles resulted also positive with high positivity for SSA antibodies and positivity for RO52 antibodies. Homocysteine level resulted within normal range, and antinuclear antibodies was negative. According to clinical criteria and laboratory results, the diagnosis for this woman is antiphospholipid syndrome with anticardiolipin IgM positive, anti-beta-2 glycoprotein IgM positive, phosphatidylserine IgM positive, phosphatidylcholine IgM positive with normal homocysteine and negative thrombophilia. This patient was tested also after 12 weeks according to the recommendation of antiphospholipid classification criteria, and continuous positivity for anticardiolipin and anti-beta-2 glycoprotein IgM reconfirmed antiphospholipid syndrome diagnosis. In this case, antiphospholipid syndrome is associated with another autoimmune condition because this patient suffers from Hashimoto thyroiditis. Thyroid hormone levels are 1.47 for TSH and 122.7 for antithyroid peroxidase. The medical treatment began immediately after the initial diagnosis and included plaquenil 200 milligrams on tablet per day, Medrol 4 milligrams, 1 tablet by mouth following breakfast. Omeprazole 1 tablet by mouth on empty stomach before breakfast. Aspirin Protect 100 milligram, 1 tablet by mouth following lunch. And vitamin D 2000 unit, 1 tablet per day in the morning. Clinical situation appears to be stabilized and under control upon the receipt of medical protocol for 6 months. The continuous follow-up is very important to ensure monitoring of all clinical and laboratory parameters. In this table, we have all data for all examination from day 1 until today. As we can see, laboratory data presented in the table show persistent positivity for IgM, cardiolipin, and IgM, anti-2 beta-glucoglycoprotein through all tests performed. Lupus anticoagulant remain negative in all tests, as well as homocysteine levels. And for the antinuclear antibodies, it's resulted negative. And in NO profiles, it is represented a low positivity for SSA antibody and for RO52 antibodies that highly suggests for Sjögren's syndrome, but until now without any clinical expression. According to the medical treatment, this patient for a short period of time, except aspirin Protect, used another anticoagulant like Xarelto, 20 milligram per day, due to high values of the dimer that resulting during additional tests through monitoring. Currently, she is taking the first plan of treatment, but without Medrol. Last laboratory results showed more positivity in realized tests, and this suggests to consider performing testing every 6 months to ensure complete monitoring and safe health. One of the causes of intrauterine growth restriction may be antiphospholipid antibody, antiphospholipid syndrome, sorry. And in those patients, it has an incidence between 6.7% and 16%. In a systematic review and meta-analysis realized to show the link between intrauterine growth restriction and antiphospholipid antibodies, was found that presence of antiphospholipid antibodies elevates the odds of intrauterine growth restriction 1.26 times. And this case report is an example that shows not only the association of antiphospholipid antibodies and intrauterine growth restriction, but at the same time is another evidence for intrauterine growth restriction caused by antiphospholipid syndrome. In another study realized in China, the aim of which was to identify the risk factors for pregnancy outcomes in women with antiphospholipid antibodies positivity, was found that incidence of intrauterine growth restriction was significantly higher in antiphospholipid antibody carriers than in normal pregnancy. And among risk factors like age, IVF, pregnancy losses related with treatments, anticardiolipin positivity was the only variable strongly associated with intrauterine growth restriction. Our laboratory findings for this patient with cardiolipin IgM positivity, beta-2-glycoprotein IgM positivity, choline IgM positivity, serine IgM positivity correlate with studies that we mentioned above. According to another study realized by Sakone et al., anti-beta-2-glycoprotein is the one associated with the lowest live birth rate and highest incidence of preeclampsia, intrauterine growth restriction, and stillbirth compared with the presence of anticardiolipin antibodies or lupus anticoagulant alone. This case report is important because it provides another evidence among controversial studies between association of antiphospholipid syndrome and intrauterine growth restriction, referring to different studies that we discussed. And early testing for antiphospholipid antibodies in patients who are experiencing intrauterine growth restriction may be beneficial in order to be excluded antiphospholipid syndrome as a probable diagnosis or be early treated without causing further damages. Continuous follow-up in patients diagnosed with antiphospholipid syndrome is very important to ensure monitoring of laboratory parameters in order to reduce the risk for another thrombotic events. Thank you for your attention and have a good day.